finally put to bed this question. I think this debate will solve the issue of what do we do for a 1 centimeter neck. Should we do fenestrated grafts, or can you use standard conventional grafts? Dr. Stoner, you're going to tell us that we need to go fenestrated grafts for all these.
Right. Well, we'll take a try. I'm going to cut to the chase. The data sucks on this, so it's hard to figure this out. Hot off the plane, also, I got ice delayed in Rochester, and I think he sent me a funny text about living on the East Coast. So my disclosures are shown. First, I thought I'd show a little trip down memory lane for Sean, sitting in my immediate right now, and then his picture greets me every morning when I walk out of my office on this glorious row of vascular leaders and mugshots. And I just thought I would remind Sean of his roots, and it's good to be back to have you here, Sean, to be together and to talk about this topic. And I think this is a really interesting topic, because looking at the anatomy, it is a really heterogeneous anatomy that's difficult to dissect out. But as we know, endovascular AAA, and certainly over my career, and I'm just sort of a mid-career person, and there's some more sage people in this room than I, is now driven largely by anatomic factors, and those anatomic factors are rapidly declining. When I was in training, it was a physiologic selection case, and I couldn't imagine why anyone was doing this to a human being. It would take 12 hours and all that. But we've moved this, and this is patient preference, and it's obviously here to stay, and it's pushed EVARs into increasingly more and more adverse anatomies, because those anatomic selection criteria continue to shrink. And this is a NISQIP paper from our site back when they stratified EVAR repair codes by CPT code. But the important part really is just what I show there about the infrarenal anatomy. And these are cases inside the NISQIP vascular specific portion of NISQIP, the national data set, that fit EVAR anatomy. And I'm sure that this is also an underrepresentation, but roughly 10% of cases already just reported to NISQIP are done outside of their IFU anatomy. So obviously your partner's EVAR is shown on the left and yours is shown on the right. But that's the anatomic severity grading, and the neck characteristics are largely the most important, I would postulate to the room, about that long-term durability. And I will have a little bit about SAC regression, but I would assume that everyone in the room at least buys the finding that SAC regression, while maybe not always causal, is a correlate of long-term success from endovascular AAA, and as such should be used as a metric for success in patients. And failure of regression or a static aneurysm is not as good as an aneurysm that regresses. So the real question, I think, in this debate is, what's the fate of the aortic neck? And we have worsening anatomies, and there are important changes in the aortic neck that happen over time after implant of the graft. And there are device engineering roles that play outside the confines of this talk. There's roles for things like active fixation, staples, pharmacology. And I would say to you, the solution is a better, more proximal seal into healthy aorta. These are outcomes of hostile neck. This is an older paper from Abu Rama's group, but basically the bottom line is, if you have hostile neck characteristics, the table shown on the right demonstrates a high early type 1 endoleak rate requiring cuffing and adjunct. So at a bare minimum becomes a more technically advanced case, a more costly case. And then over time, though, what begins to happen is the aortic neck dilates. And we know that the nature of the aorta, and the dovetail in Dr. Criado's talk, it becomes a stiffened structure, it loses elastin, and it dies over time, essentially. And those of us in the room who open the aorta and operate and explant grafts as well, as I'm sure Dr. Leiden does as well, it's a dead tube when you go in there to explant that graft. It's a pure collagen tube. It has a widened pulse pressure. It is completely biologically failed. So that aortic neck dilation essentially can be thought of as a cancer. It extends up from the aneurysm and continues to fall apart. So aortic neck dilation happens at a rate of approximately 26% of the aortic neck approaching the nominal size of the stent graft. And if you look at different meta-analyses, they all come up with similar numbers, but the bottom line is, if you have aortic neck degeneration, it is associated with a clinical event, type 1 endoleak, migration, or need for reintervention. So obviously the caveats in the aortic neck dilation literature is it's heterogeneous. The publications are often single center, they're pooled, they're not standardized controlled, but we do know in our own clinical practices and high volume EVAR practices that that aortic proximal neck is the problem over time. There are some interesting device specific notes, and they're hard to generalize, so I'll just kind of skip over them, because again, different trials will find different things with different device biomaterials and postulates, probably because the biology is also heterogeneous as well. So this is a European study that looked at standard EVAR and the fate of the aortic neck in patients undergoing standard endovascular repair with a self-expanding stent graft. So a standard stent graft, and their methodology is shown here in terms of axial and centerline type imaging. But the interesting part about it is you look at the aortic neck dilation curves of those patients over time, and there's a trend, again, for the aortic neck to simply degenerate and get wider as things progress. And there you can see a Kaplan-Meier estimate of aortic neck generation for that population. There is some play. Again, I said I'd skip over some of the device-specific characteristics. There may be some device radial force issues at play, and certainly we had a much cruder process of measuring aortic neck when I was in training compared to now and all the 3D software that we have. We have different devices now with different characteristics, different metal alloys, different fabrics. There may be some role of device in terms of aortic neck dilation. There is some, the consensus seems to be that a Gore excluder device, which may be a softer device, may be a little bit better. Some of the other polymer-based devices may be better. Again, there's no randomized data or head-to-head data that really look at this in the long term for neck degeneration, but there may be some device-specific issues. So what about when you look at the hostile neck? So certainly, there are devices on the market with a 1 centimeter indication. There's a Z-Fen on the market with a 4 millimeter neck indication, right? But if you look at it, this is a VQI study, looked at hostile neck characteristics, and you can see on the left the varying elements of hostile neck, but the protective factor was neck length per 5 millimeters. So as the neck gets longer, it is protective for aortic-related events, so reintervention or all-cause mortality. So this is a study from, I think this is Ben Starnes' place, that looked at aortic neck dilation in PMEG. So this is using a modified trio endograft as part of his IDE for essentially pararenal and I think sort of extent 4 or extent 3.9 thoracoabdominal aortic aneurysms. And if you look at that with this aortic neck dilation is shown on the graph on the left, but the important part is despite the aortic neck dilation, that more proximal seal is protective for aneurysm size and regression. This is a study that looks at fenestrated aortic endografts as a first-line treatment for proximal seal. And I just bring this up to say that this is a 2015 study, so 10 years ago, just about, in terms of learning curve, and even demonstrates a 96% technical success, 98.1% target vessel patency, and a 90% freedom for intervention. So even 10 years ago, with these technologies in this European study, demonstrates an excellent ability to get the graft in. This is the interesting thing about it, though. If you look at this is Z-Fen SAC regression study, so this is from Stanford. And so this isn't just showing, this is not comparing Z-Fen to another product, these are just Z-Fen cases. But the interesting part to kind of support what I'm postulating here about the aortic neck degenerates over time, if you look at factors related to regression versus failure of regression in Z-Fen cases. And if you look there, the important regression finding is shown in the middle of the table there, which is a device of 32 millimeters. So when you have to put the largest devices in, the necks will degenerate. So I think that, obviously the topic I was assigned was about neck length, and I'm sort of generalizing this, that the neck degenerates over time. And that neck length and that neck diameter are often linked, and I think that they should be looked at together. So this is a real complicated study, and the math and the statistics behind this are borderline mind-boggling. Like I wouldn't know what to do if I was asked to review this paper for the journal, because I read through this several times. So this is a pooled meta-analysis type paper, and it looks at comparator studies of IFU EVAR, chimney EVAR, and fenestrated grafts in varying neck anatomies. And so like I said, this is a really dense meta-analysis paper, and it's difficult to dissect out some of the statistics. It takes some weight to get through it. But the bottom right histogram, what it demonstrates is that factors associated with failure over time. So and those are the different treatment modalities shown on the bottom axis. So CHEVAR, FEVAR, EVAR, and open repair. But the bottom line is that off-IFU EVAR and chimney-based EVAR are both strongly associated with failure over time compared to open repair and Z-Fen. Now these didn't, I actually want to put a caveat with my word strongly, did not reach statistically significance in meta-analysis study, the pooled analysis of a variety of studies, but they did tend to come up as significant factors. So lastly in this whole thing, so what I'm trying to say from my side of the debate is that the aortic neck falls apart over time. It's essentially cancer of the aorta. The aneurysm is cancer, it continues to progress. Patients are never cured, they're only in regression from their disease process, right? So there's got to be something else about the biology we have to start paying attention to, and this dovetails again on Dr. Priato's talk. It's going to be the stiffness, the makeup of the elastin content. Can we preserve the elastin content in that seal zone? I would say that many of these 1 centimeter nicks probably represent stiffer aortas with a larger collagen content. They are dead tubes already, non-compliant tubes, and they will completely fail over time. So the real selection process for this is going to be going more proximal to preserved aortic structure, which is where the fenestrated graft theoretically sits in that realm, avoiding this part of the tube that's simply going to fall apart over time. So the take-home points, I think, for all of us in this room is to beware of just getting the graft in and achieving the angiographic seal, right? So beware of the infrarenal graft in what is really juxtarenal anatomy. Open aneurysm repair is still valid. It often now will require centers of excellence and volumes to justify it, so probably not every vascular surgeon is capable of a very low morbidity mortality open aneurysm repair. But ZFEN, PMEG, branch graft to get to more proximal seal, obviously this needs to be balanced versus patient longevity and by risk of things like spinal cord paralysis, length of case. There's an economic consideration as well, which I've skipped over also. We all know that if you have a complex aortic program, you hope your hospital administrator doesn't overly pay attention to it because it is a loss leader for your vascular program. But likely at play, there are also device aortic material property interfaces at play that we don't really understand. Active fixation and anchors may be an adjunct for this. Again, you may be just putting anchors in the 4 millimeter neck, which is exceedingly difficult, into a dead tube also. But the aorta does keep degenerating, so just fen it. Thank you.